Very good afternoon to all of you. At the outset, I thank organizers for giving me this opportunity. Today, I will be speaking on approach to hypertension in children and adolescents. For many years after I started practice, hypertension was a less important topic for me. As a general pediatrician, my thinking was very simple. Why to waste energy on this? Rather focus on more common things. But over a period of time, I realized that though hypertension is less common, it is not uncommon. And as the prevalence of obesity is rising nowadays, I think we all must give due importance to this topic also. And the basic idea of this talk was to encourage everybody to start using BP tables in the office practice. During the next 15 minutes, I will cover this topic under these headings. First, definition. Definition of hypertension is different for children age 1 to less than 13 years and different for adolescents age 13 and more. In children, definition is percentile based. Therefore, it is essential for everybody to use BP tables. Whereas in adolescents, definition based on millimeter of mercury, so it is very easy to understand. So let us begin with the simple thing first. In the definition, one has to remember the four different categories: normal BP, elevated BP, stage 1 and stage 2 hypertension. In case of adolescents, the normal BP is systolic BP less than 120 and diastolic BP less than 80. Elevated BP is systolic BP between 120 to 129 and diastolic BP less than 80. Stage 1 hypertension is systolic BP between 130 to 139 and diastolic BP between 80 to 89, whereas stage 2 hypertension is systolic BP of 140 and more or diastolic BP of 90 or more. In case of children, normal BP is BP less than 90th percentile, elevated BP is BP more than or equal to 90th percentile to less than 95th percentile, or BP of 120 by 80 to less than 90th percentile, 95th percentile, whichever is lower. Stage 1 hypertension is systolic BP, diastolic BP more than or equal to 95th percentile to less than 95th percentile plus 12 millimeter of mercury, or BP of 130 by 80 to 139 by 89, whichever is lower. Stage 2 hypertension is BP more than or equal to 95th percentile plus 12 millimeter of mercury, or BP of 140 by 90 or more, whichever is lower. From definition, it is very clear that to diagnose hypertension in children, one has to know the BP percentile values, and these percentile values are given in BP table. Now look at the BP table. This is the BP table for just 1 year old male child. What is your first impression? This is a discouraging, because lots of values are given and this automatically forces everybody not to look at the chart and not to use it. But believe me, this is a very simple chart. So let us understand the different parts of the chart. To the extreme left is the age category. This table is available from the age ranging from 1 to 17 years. The next column shows BP percentile values. Here 4 percentile values are given: 50th, 90th, 95th and 95th plus 12 millimeter of mercury. These 4 values will give us idea about the different 4 categories which we have already seen in the definition. The 50th percentile value will give us idea about the average normal blood pressure for that particular age. 90th percentile value will give us idea about the elevated BP. 95th percentile value will give us idea about the stage 1, and 95th plus 12 millimeter of mercury will give us idea about the stage 2 hypertension. Then to the left side is the systolic BP and to the right side is the diastolic BP. Below systolic and diastolic BP, height is given in 3 formats. One, height percentile ranging from 5th to 95th, and height in inches and height in centimeter. So this is the structure of a BP table. Now how to use this BP table? The basic purpose of BP table is to find out what is the 90th percentile value for that particular age and for that height, because that will decide whether the child has a normal BP or elevated BP. So first thing is record the blood pressure of the child. Second step, record the height of the child. Then select gender appropriate charts, because the BP table is different for boys and different for the girls. Then find out the age of the child. So The next step is to draw a horizontal line across the table. Horizontal line across the table beginning from the 90th percentile value. Okay, from the proper age category, draw a horizontal line across the table. Then draw another vertical line from the height section. The point at which these lines intersect each other is the 90th percentile value for that child. So similarly, draw the 90th percentile for the systolic BP and draw the 90th percentile for the diastolic BP. And if the recorded blood pressure value is less than this 90th percentile, then the child has a normal BP. And if the recorded BP is more than the 90th percentile, then the child has a elevated BP. Once you confirm that the child has elevated BP, then the next step is to find out whether he has a stage 1 or stage 2 hypertension. In the same way, one has to find out what is the 95th percentile and what is the 95th plus 12 millimeter of mercury percentile. So this 95th percentile value will give us an idea about stage 1 and 95th plus 12 will give us idea about the stage 2 hypertension. So this is all about the BP table. But if anyone thinks that this chart is very difficult, cumbersome, and in a busy OPD it is very difficult to use, then what is the answer? Then the answer is a simplified BP table. So what is this? In a busy OPD, one has to use this as a screening method. So here again the BP values are given for boys as well as the girls, ranging from the age 1 year onwards. Systolic and diastolic values are given. So what is the feature of this? This gives the 90th percentile value for the particular age category. That means for the age 2, the 90th percentile systolic is 100 and diastolic is 55 for the boys. That means if the recorded blood pressure is less than the value shown in this chart, then the child has a normal BP, and if the recorded blood pressure value is more than what is given in the chart, then the child has elevated BP, and such child needs further detailed evaluation. Now how to measure the BP? The child should be seated in a quiet room for 3 to 5 minutes before measurement with the back supported and feet uncrossed on the floor. BP should be measured in the right arm for consistency. The correct size cuff should be used. The bladder length should be around 80 to 100% of the arm circumference, and the width should be at least 40%. Initial BP measurement may be auscultatory or oscillometric. If the BP is elevated, take 2 more readings at the same visit and average them, and this average reading is used to determine the child's BP category. Measures obtained by oscillometric devices that exceeds the 90th percentile value should be repeated by auscultation. What is the BP measurement frequency? The guideline recommends annual BP measurement for all children whose age is 3 or more. But in certain special situations, the blood pressure of these children should be measured at every time. And these conditions are if the child is obese with BMI more than 95th percentile, if the child has renal disease, diabetes, coarctation of aorta, and if he is under some medication which are likely to raise the blood pressure. And what about those who are less than 3 years old? The blood pressure of this smaller group of children should also be measured in certain special situations, and these are elaborated here. If there is history of prematurity, gestational age of less than 32 weeks, very low birth weight baby, if the baby has a congenital heart disease, repaired or unrepaired, renal diseases, urological malformation, if the child has a recurrent UTI, hematuria, proteinuria, family history of congenital renal disease, solid organ transplant, malignancy, bone marrow transplant, treatment with drugs which are known to raise the BP, systemic illnesses such as neurofibromatosis, tuberous sclerosis, and if there is evidence of raised intracranial tension. What are the different devices which one can use? These are either manual or automatic. In manual we have the standard mercury manometer, and second one aneroid, where mercury is not used for the measurement. And in automatic devices we have digital manometer, multiparameters, and ambulatory blood pressure monitoring devices. These automatic devices are very useful in NICU and POC setup. So what is this ABPM? ABPM is ambulatory blood pressure monitoring device which measures the blood pressure of a child over a period of 24 hours, and it gives us very additional information in the form of average daytime BP, average night BP, nightfall in the BP, preload of, as well as the 24 hours average of the BP. And this type of measuring device is very essential in the diagnosis of white coat hypertension. What is white coat hypertension? Hypertension in an office setting and normal tension at home is called as a white coat hypertension. Now what is the etiology of hypertension? It is either a primary, where no obvious cause is found, or secondary, when some underlying cause is present. What are the characteristic features of primary or essential hypertension? It is usually found in older children and adolescents, always there is a positive family history of hypertension present. Child is either overweight or obese, and history as well as clinical examination reveals nothing. The no underlying secondary cause is found. And what is the characteristic feature of secondary hypertension? Smaller child with hypertension. That means if you come across a small child with hypertension, definitely there is some cause, some system is involved. And the common four systems which are involved are renal, vascular, endocrine, and central nervous system. And out of these four systems, the most commonly involved system is the renal one. What are the clinical features? The mild elevation in BP will not give rise to any symptoms, but sometimes non-specific symptoms such as headache, dizziness, and nosebleeds may occur. The signs and symptoms will be present if there is a hypertension is present for a prolonged period of time, or if there is a sudden rise in hypertension. And this sudden rise in the hypertension, called as acute presentation, is divided into two categories: either hypertensive urgency or hypertensive emergency. In hypertensive urgency, sudden development of elevated BP is not associated with end organ damage, whereas in hypertensive emergency, end organ damage is present. And such patient presents with hypertensive encephalopathy. Features will be like headache, vomiting, altered sensorium, seizures. Sometimes patients may present with visual impairment due to retinal hemorrhages, acute kidney injury, pulmonary edema, and congestive cardiac failure. Now, once the diagnosis is confirmed, then what is the next? Next is a diagnostic evaluation. Diagnostic evaluation is essential to determine the possible cause as well as to determine the associated comorbidities and target organ damage. History, physical examination, lab investigations, and imaging study, they play an important role in the diagnostic evaluation. One has to obtain a detailed history starting from the prenatal time. What was the birth weight? What was the gestational age? Whether any maternal complications like hypertension was present or not. Whether the child has undergone umbilical artery catheterization. Get a detailed nutritional history of a child. Find out how much physically active is child or he is inactive. The history of renal disease is also important. How many episodes of urinary tract infection child has suffered in the past? Is there any history of edema, hematuria, enuresis, or nocturia? The family history of hypertension as well as the congenital renal disease is also very important. And in case of adolescents, history of smoking and alcohol is very important. Physical examination also will give us various clues regarding the underlying secondary cause of this hypertension. The slide shows various physical findings and the possible etiology. For example, if there are decreased lower extremity pulses and drop in BP from upper to lower extremity, then it is a coarctation of aorta. If there are cafe ovulate spots, it points toward the neurofibromatosis. If the child has acne, hirsutism, stria, then it favors Cushing syndrome. If there is a acanthosis nigricans, then it favors type 2 diabetes mellitus. If the child has a chest pain, palpitation, exertional dyspnea, heart murmur, then most probably you are dealing with a cardiac cause. If the child has an abdominal mass, palpable kidney, and abdominal bruit, definitely some renal cause is there. And if there is ambiguous genitalia, definitely you consider for congenital adrenal hyperplasia. So what investigation one should do in such cases? All patients should be done urine analysis, CBC, renal function test, lipid profile, as well as USG-QUB. And in obese individuals and adolescents, few more additional investigations are required, and these are glycosylated hemoglobin, SGPT, SGOT for fatty liver, fasting lipid profile for dyslipidemia, blood sugar fasting, as well as postprandial. And if the history and physical examination suggests some special condition, then some special investigations are also required, such as thyroid function test and drug screen. In imaging evaluation, one has to consider two non-invasive screening tests. One is the echo and second one is the Doppler renal USG. Echo is very essential for the assessment of cardiac organ damage at the time of consideration of pharmacological treatment of hypertension. And based on three important parameters: left ventricular hypertrophy, left ventricular wall thickness, and left ventricular ejection fraction, whether the cardiac organ is fine or there is some damage is determined. Doppler renal USG is also useful in the evaluation of a renal artery stenosis in a normal weight children whose age is 8 years or more, and in adolescents who will cooperate with the procedures. Now, everything is done. Now, how to treat? The goal of the treatment is reduction in systolic and diastolic blood pressure to less than 90th percentile. And two types of treatments are advised: non-pharmacological and pharmacological. Non-pharmacological intervention is also called as a lifestyle modification. It consists of diet, physical activity, and weight loss for obese children. The child is advised to take whole grains, pulses, fresh fruits, fresh vegetables, fiber-rich diet, and low-fat containing milk products. Low sodium intake is advised. Limited intake of sugar and sweet beverages is advised. Child is advised to take regular physical aerobic activity at least 3 to 5 days per week for at least each session should last for at least 30 to 60 minutes. Reduction of sedentary activity is also advised to less than 2 hours per day. And the different categories of drug which one can use in the treatment are 4 ACE inhibitors such as enalapril, captopril, angiotensin receptor blockers like losartan, olmesartan, thiazide diuretics like hydrochlorothiazide, chlorthalidone, and calcium channel blockers like amlodipine, nifedipine, extended release, felodipine, and isradipine. And what are the indication where you are going to use this drug? These are the indications for the drug use: symptomatic hypertension, stage 2 hypertension without a clearly modifiable factor such as obesity, any stage of hypertension associated with chronic kidney disease and diabetes mellitus, persistent hypertension despite a trial of lifestyle modification, and hypertensive target organ damage. So start with the single drug. Start with the initial recommended dose. Gradually increase the dose and see whether the patient is responding to it or not. Try to reach up to the maximum possible dose. If the patient does not respond, then add second drug from the second different category and see how the patient is responding. And even if the patient does not respond to the 2 different class of drugs, then it is better to refer this patient to a person who is specialized in the treatment of childhood hypertension. Thank you.